For most family practices in 2025, the math of keeping the doors open is getting tighter. According to the latest MGMA polling, 90% of medical groups report their operating costs are higher right now than they were at the exact same point last year. A major piece of that squeeze comes from the back office. Over the past decade, administrative and billing wages have surged, pulling a larger share of every revenue dollar into overhead. When a practice hires an in-house biller, the $55,000 to $75,000 base salary is only the starting line. Once you factor in a 20 to 30% markup for benefits, plus software subscriptions, clearinghouse fees, IT support, and ongoing training, the real cost spirals. As we add benefits, software, and overhead to the base salary, the fully loaded cost of a single in-house billing seat easily reaches $90,000 to $140,000 per year before they process a single claim. And if that staff member leaves for a remote job at a larger health system, you reset the clock. Replacing a medical billing team member costs an average of $9,000 to $12,000 per departure in lost time and recruiting. Factoring in these numbers, maintaining a physical in-house billing department represents a massive, ongoing drain on a practice's operating margins. That high overhead might be acceptable if it guaranteed perfect revenue collection, but industry-wide, the volume of denied claims is actively climbing. From 2020 to 2024, initial claim denial rates hit 11.8%, alongside a 30% spike in payer audits. Reworking a single commercial denial costs $63.76. Because of this bottleneck, 65% of denied claims are never resubmitted at all. For a family practice collecting $1 million annually, that translates to at least $48,000 walking out the door every single year as uncollected revenue. The comfort of having a biller working down the hall is heavily outweighed by the slow, quiet bleed of unworked claim denials. The reason even experienced local staff struggle is the sheer density of family medicine. A single provider might cycle through chronic disease management, telehealth, and preventative care all in the same morning. Each of those encounter types carries specific modifier rules and payer requirements. In fact, Medicare data from 2024 shows insufficient documentation remains the absolute leading driver of claim errors across specialties. A generalist administrative hire who learned billing on the job will naturally lack the deep payer-specific nuance required to get those complex claims paid on the first pass. When those coding errors create late-day calls from the revenue cycle team, it adds direct friction to the physician's day. It is a major reason why 45% of family medicine physicians report symptoms of burnout. The traditional reaction to this backlog is to hire another local administrative assistant, which simply restarts the expensive cycle of onboarding and turnover. To protect their margins, successful practices are completely separating the task of medical billing from their internal payroll, opting instead for remote, highly specialized teams. Navigating modern payer requirements demands specialized credentialing that most practices simply cannot source from a local hiring pool. This is where Staffingly provides a specialized alternative. They deploy dedicated billing teams that work securely inside a practice's existing electronic medical record system. Instead of generalist hires, these teams are built around AAPC and AHEMA credentialed specialists. These are the gold standards in professional coding. This flowchart illustrates the technical connection. The remote specialist links directly into the central EMR database via a secure, encrypted VPN. This means there is zero screen share lag and no workflow translation loss. The operational rollout begins with an initial kickoff, followed immediately by establishing that secure EMR connection. Next is team onboarding. The dedicated specialists spend this time learning the practice's unique patient population, payer mix, and specific documentation preferences. By the 14-day mark, the team goes live through a risk-free pilot period, utilizing daily quality reviews to guarantee immediate accuracy. Finally, the team implements a structured weekly performance recap to track first-pass resolution and turnaround times. Real operational control requires verifiable metrics and certified execution, rather than simply watching an employee sit at a desk. To keep pace with the massive volume of payer data, Staffingly runs these billing workflows on AI-augmented systems. Smart routing and predictive workload management instantly assign incoming claims to the correct workflow path based on complexity and payer rules. Before a claim is ever submitted, automated audit checks run a daily claim scrubbing process to catch and flag common coding errors. By catching those mismatches before they hit the clearinghouse, this process consistently drives the initial error rate below 1%. The technology handles the repetitive pattern detection, freeing the human credentialed expert to focus entirely on closing complex claims and capturing revenue. When comparing the financial profiles of these two approaches side by side, the math clarifies the decision. The traditional in-house model demands constant management effort, carries extreme turnover risk, and drains up to $140,000 in fully loaded overhead per biller. This matrix highlights the alternative. On the right, Staffingly provides immediate, credentialed expertise with an error rate below 1% at $399 per week. That calculates to roughly $20,700 per seat annually, protecting nearly $100,000 in operating margins compared to the in-house baseline. Outsourcing removes fixed payroll constraints. Operating on a month-to-month contract allows a practice to scale seats up or down with 30 days' notice. For administrators prioritizing net collection rates and scalability, the financial calculation heavily favors an outsourced model. This operational shift is built directly for family practices feeling the margin squeeze, who need immediate relief from rising denial rates and EMR complexity. It's not a fit for practices that refuse to adapt their documentation habits to remote workflows, or those that value physical staff oversight above their financial margins. If rising overhead is restricting your growth, run the exact math on your internal billing costs. Then initiate a 14-day risk-free pilot with Staffingly to start reclaiming your hard-earned revenue.